welcome back, everyone. And we've had a wonderful lunch and great session this morning, questions and answers. And part of what we do annually is to try and bring new and interesting projects, information, and people. Because this is a chance that we work through the novelties of what's out there. We're going to try and assimilate the information of the work around NMO, treatment strategies, and all the things on the cutting edge that may or may not be useful together. And that's to Michael Yeaman's point. It's not about us, it's not about you, it's about us as a group. I have a distinguished pleasure to introduce our next speaker. This afternoon, we have a few interesting people, and we begin with Dr. Richard Burt. He is from Northwestern University. He is trained in hematology oncology, and after many years of work in that field, has become a distinguished investigator and clinician in the area of stem cell transplantation. He reminded me of an important fact, which is that in 2006, Scientific American named him as one of the top 50 people in the country for the improvement in humanitarian works. And that's significant because we are all humans, people together trying to solve this. I have to say that his work is extraordinarily interesting. And then our attorneys will kill us if I don't say, for our speakers who are on cutting-edge research, we have to understand that as a foundation, we don't endorse treatment strategies or other entities. We look into them and we provide information. We look very much forward to Dr. Burt's information. Thank you.
Well, thank you very much. It's always a pleasure to speak to an audience of patients. And if for some reason you don't hear me very well, just raise your hands. But we only have a limited amount of time, so I'll have to go a little bit faster than I wanted to. And what we're going to talk about is the use of hematopoietic stem cells, HSCT, hematopoietic stem cell transplant for autoimmune diseases. And we have a letter in Science May 14th of this year about it, if you want to go to that under my name as first author. But basically, why would this work? It's been known in immunology for a long, long time that the response of the immune system to an antigen depends on how that antigen is presented. So if it's presented in an inflammatory, co-stimulatory environment, the immune system becomes activated. If it's not, it'll ignore it, or if you will, treat it with respect. So all we do is take patients with bad autoimmune disorders, and we use a regimen to knock down their immune system to induce an immediate ceasefire to stop the inflammation. And then we allow the immune stem cell to regenerate your immune compartment in a non-inflammatory environment. And when it does that, the default of the immune system is tolerance to self. So that was the hypothesis. We worked in animals I began about 20 to 24 years ago and eventually went to human trials. First one about 13 years ago, and then expanded them in different autoimmune diseases and in trials phase 1, phase 2, phase 3, phase 1 safety, phase 2 efficacy, phase 3 randomized trials. So different autoimmune diseases are in different stages. And we looked at immune analysis, not just in the animals some time ago, but in patients. And that statement is holding up. When the immune system regenerates in a non-inflammatory environment where we've induced this ceasefire, the default is tolerance to self. Okay? Our most recent paper happened to be in patients with lupus in Journal of Immunology in November of 2009. Antigen-specific tolerance is actually what we showed with this treatment. But in any event, that's the rationale behind this. And there's a couple points I want to make. One is, our conditioning regimen is not like the regimens from cancer. I know, in a different life, I used to do stem cell transplants for leukemia. We do not use cancer drugs. Our goal is not to destroy the bone marrow. Our goal is only to knock down the immune compartment, one part of the bone marrow. So that leads to using standard immune suppressive drugs, but at higher doses. Now, one drug we use, cyclophosphamide, is immune suppressive drug. It's used normally by neurologists and rheumatologists, dermatologists, so forth. But we use it at a higher dose, a dose that's used for treatment of lymphomas, because a lymphoma is a cancer of an immune system. So it can also be a chemotherapy drug, but that's the only one. But it's still immune suppressive, and it doesn't destroy your entire bone marrow. And so that leads to what I say here, non-myeloablative, because autologous transplant, autologous, your own stem cells, transplant in cancer is always myeloablative. If they don't give you those stem cells, you won't recover. Ours is non-myeloablative. You will recover fine without them. We only give them to hasten the recovery, so you recover about 4 days sooner and out of the hospital. So in fact, in reality, I must, because of the field I'm in, use the word transplant. But there's no transplant. It's an autologous blood product. The analogy is if you need surgery and the doctor takes red blood cells from you, a unit, does a surgery, and after surgery gives them back to you. That's just a transfusion of your own red cells, so that you recover faster and get out of the hospital sooner. So instead of surgery, we use immune suppressive drugs that are maximized to target and knock down your immune system, and then we give the stem cells so you recover faster. We don't have to give them. And of course, we collect them before. Now, again, we used in almost all of our studies autologous, meaning your own. So the genetic predisposition to whatever's going on in terms of an autoimmune disease is still there. So it could, yes, come back. But oftentimes a good part of your life you've gone without these disorders before it showed up. We could also use allogeneic, that is a brother or sister or an unrelated donor. And in fact, in some of our autoimmune studies, we've gone to allogeneic as well. We do that in systemic sclerosis. We have some other protocols for allogeneic. Because if you do allogeneic, not only can you knock down the immune system and give these stem cells in a non-inflammatory environment where the default in regeneration is tolerance to self, but you change genetic predisposition because they're not your own stem cells. The genes are different. Even in your brother or sister, as you know, the genes are different. We haven't yet devised any of those allogeneic protocols for any neurologic disease. We probably will in the future because we wanted to first show we could do it without graft versus host disease, and we haven't had any at all in our other autoimmune diseases that we're treating. So we're going to limit in this about autologous transplant right now, and they're all non-myeloablative. Here are some of the diseases, autoimmune diseases, immune-mediated disorders we treat: multiple sclerosis, CIDP, myasthenia gravis, and Devix. Here, these are all neurologic disorders: lupus, systemic sclerosis, rheumatoid arthritis, polymyositis, rheumatologic vasculitis, could fall in many different specialties, autoimmune blindness in ophthalmology, type 1 diabetes in endocrinology, and Crohn's disease, which is a GI disorder. Well, today, to give you some background as to how this began, we'll just focus on these three, and we'll start where it began with my original work in multiple sclerosis, which began 24 years ago in the basement laboratory at Johns Hopkins. And we started with an animal model of multiple sclerosis for preclinical proof that this could work. And our animal model was EAE, experimental autoimmune encephalomyelitis. And we know it's autoimmune because you can take particular peptides from myelin in the brain, vaccinate the animal, and induce a demyelinating disease that's used as a model for MS. So, and you can take splenocytes or lymphocytes from a mouse that has the disease and transfer it to another mouse, and that mouse will get the disease. So we know it's immune-mediated. Obviously, in a human being, that would be the proof of an autoimmune disease, but you can't do that. You can't take someone's lymphocyte and give them someone else to try to cause a disease. But we can do it in animals, and when we did the transplant, so here's neurologic disability. So they're getting worse neurologically here at onset. If we did the treatment here at peak of disease of neurologic dysfunction, those that got the transplant regimen just got better and stayed better, never completely normal, continued to do better. Those that didn't, they remitted and then they relapsed, because it is a relapsing-remitting disease like relapsing-remitting MS. Out here, this was from a paper. We did a lot of immune analysis on these animals, looking at what's going on with the immune system between the two arms. And importantly, if we just infused stem cells, it didn't work. We had to add the conditioning regimen to stop the inflammation. We call it a conditioning regimen, but those are those immune-specific drugs to knock down the immune system, stop the ongoing inflammation. Again, how an antigen is presented to the immune system helps determine its response. Your immune system is your police force. If you walk up to a policeman and you smart off to him, you might get your head cracked, even though you're a good citizen. The problem is, if that happens enough when the police are dealing with a certain ethnicity or race or religion or whatever, the police can no longer discriminate good from bad and can go out there just cracking people who are doing nothing wrong at all because they look a certain way. Well, what we do is we remove the police force, start with new recruits in a non-inflammatory environment where there isn't this initial aggression, and what happens is the police, at worst, ignore good citizens and ideally treat them with respect. So that's what we do. And so it did work. Let's see. Now, if we did it later in the disease, and we published this as well, so if we wait way out here later in the disease, it didn't work. It didn't have any effect whether we did a transplant or not in terms of disability in these mice. And that told us something in this neurologic disease that was a model for MS, that if we treated early, it worked. If we waited until it became chronic, it didn't work. And in fact, that was our conclusion. Hematopoietic stem cells. And again, I'm limited by terminology. When I say it's a transplant, there's not really a transplant. It's an autologous supportive blood product. When I say hematopoietic, that's the term, but it is also the immune stem cell. So you could just say immune stem cell transplant as well. It is your immune stem cell as well. So the hematopoietic stem cells were ineffective without the conditioning regimen. And sometimes I get ahead of myself. These are adult stem cells. They're not embryonic. They're from you yourself. So anyway, it's not effective without the conditioning regimen. It is effective in relapsing-remitting EAE model of MS. It's ineffective in the progressive phase of disease in these animals. Well, a lot of things worked in EAE that when you try them in humans didn't work. And the reason was because people treat mice early. They're expensive to keep, and they don't wait a couple months with chronic disease before they start treatment, but with human beings, they would apply the results of what they used in the mice early to people with progressive MS, late MS, and it doesn't help. In fact, there's no immune modulating therapy that really works in late progressive MS, and that's consistent with our animal model EAE. So relapsing remitting, you have an attack, you get better, kind of like Devix, hopefully get better. But, sometimes you have an attack, but you don't go back to baseline. You're still worse off. So this is permanent dysfunction. You didn't completely come back to a normal baseline like here. But in MS, you can go on to, if you wait long enough, secondary progressive, where without acute attacks, your baseline's slowly deteriorating. That is, your neurologic function slowly declining. You could see, as a physician, the patient, every month for 2 or 3 years, and you don't know when that change occurred, but at the end of 3 years, they're worse. That's progressive disease. And that's really an axonal degenerative disease, unlike this acute attacks, which is relapsing-remitting immune-mediated disorder. Well, we knew this, we have this data, but when we did our first study on MS using stem cell transplants, we were restricted by our advisory board and by regulatory boards to focus on secondary progressive MS, that is late progressive, which our animal model said it wouldn't work. But nobody had done this. So it's reasonable, because the first study is safety, to do it there. And we were hopeful maybe it still would work. But in fact, when we took people with high EDS scores to begin with, high disability, EDS disability 0 is normal, 10 would be dead, all based on neurologic function, they still progressed with increasing disability over time after the procedure. If we got them earlier, they didn't. We had shorter follow-up because we were allowed, as the study went on, to start enrolling people with little less disability. And so I published those results in 2003, and I actually put in the publication failure. Now, here I'd spent my career on this and working in animal models, but it didn't work. Didn't help the patients. And it's just as important to report negative results as positive because it says a lot about the disease. So hematopoietic stem cell transplant for progressive multiple sclerosis failure to prevent disease progression in patients with high disability scores. I'm the first author in that paper. So the hematopoietic stem cell transplant does not reverse neurologic deficits in progressive MS. But we did get immune regeneration. How do I know? Because we collected lymphocytes from the patients through lymphodepletion before the procedure and at set time points after, and sent it to the NIH, where I had spent 7 years in my career and initially started working on this with also going to Hopkins. So, and the NIH did a great immune analysis. And colleagues who I have known there were really the investigators in the lab doing it, headed by Paula Moreau here, Daniel Dewick, Henry McFarland, and Roland Martin. And I'm here because I provided the samples, and we published this in Journal of Experimental Medicine. And there was an editorial on this, and it said, who wrote the editorial, Immune Regeneration of Stem Cell Transplant, out with the old, in with the new. And I don't think for this audience I need to go into the particular assays used, but what it really showed is that there was a surge of new lymphocytes coming out of the thymus after this procedure. And the immune system changed from pre-transplant with the oligoclonality and T-cell receptors that we found in our MS patients to a more broad, diverse, normal repertoire. So there was a regeneration. And this data showed it, but what is misleading, although we did regenerate the new immune system, it didn't help the patients. Didn't help them with progressive MS. And I think that was a very important take-home point, because what we learned is no method of immune modulation, including hematopoietic stem cell transplant, which is really a short, focused bolus of immune suppression, intense enough to knock your immune compartment down to almost zero, and then you regenerate. You have a surge of regenerating new lymphocytes, new immune compartment. We did get an immune reset, but it wasn't effective in progressive MS. And I think that take-home lesson is important because a lot of patients with progressive phase of MS are treated all the time with standard immune suppressive drugs. Azathioprine, Cytoxan, Tysabri, mitoxantrone. They're given it all the time, and there's absolutely no data anywhere in the literature that says that helps those people. And I can understand the frustration. The patient comes, you want to do something, but it's too late. So a lot of money is being spent to treat a lot of people where doesn't appear to be benefiting them. There's no study to show it does benefit them. You have to treat earlier. And we also made the point that you don't want to use myeloablative cancer regimens. You want to use these non-myeloablative, gentler regimens that we use at Northwestern. And I think that's important because even though I pioneered this field, and I was the first one out there saying, this is something we should do, some other centers, because the technology for it came out of transplant for leukemias, that's where I came from, some other centers have focused on using cancer regimens. And I don't agree with that. I think the rationale, it's not necessary. Doesn't make sense, and you run a lot more toxicity if you do that, both early and late. All right, so our first trial, well, we didn't give up. We've been treating other autoimmune diseases and seeing great results, and our animal model actually held up. It predicted what happened in the patients. So we tried another protocol where we treated patients with inflammatory MS, that's relapsing remitting with frequent acute attacks despite interferon. That's a group. Now, ideally, if there was a biomarker saying this person with MS is going to end up early in a wheelchair, that's the person we would take. There's no such biomarker. But the best we got is the more attacks, the more inflammation early on, the more likely you're to end up early in a wheelchair. So that's why we took more frequent attacks despite the interferons as candidates for this procedure. And here was our regimen, and this is a non-myeloablative regimen, cyclophosphamide, rapid ATG, and we give a steroid here to prevent fever and side effects of ATG. We collect the cells with cyclophosphamide and a growth factor, and I think this is important because it gives some in vivo purge. when we collect the cells, freeze them down, give the conditioning regimen, which is over about 5 days, and infuse the cells here. And about from 7 to 12 days afterwards, the patient has been discharged and grafted and discharged. And this is what hematopoietic stem cells or immune stem cells look like, in case you'd ever wondered. They're, have a very big nucleus and small cytoplasm. They are stem cell. I was trained, always look at your own pathology, look at your own MRIs, look at your own chest x-rays, which I do to this day, and I always tell younger doctors to do that. I'm always astonished how they don't want to do that. They just want to read a report. You have to look your enemy in the eye. You have to go down and look under the microscope. You have to look at the MRIs yourself. So, these actually could be confused with blasts, which you see in leukemia, but they're not. They're not blasts. They're your normal stem cells. Well, we did this study, and what we found is exactly the opposite. So in 21 patients, exactly the opposite to our prior study in progressive MS. So in aggressive inflammatory MS, in 21 patients, 7 improved by an EDSS of 1 to 1.5, meaning the EDSS declined towards normal. Again, the scale is 0 to 10, half-point steps. You need at least a 1-point change to be considered significant. Less than that, if it's a half-a-point change, it could be within just the error or variation of the neurologist doing the exam on that day or of a different neurologist or whatever. So it's considered you want a 1 point or greater change, and in fact, 7 changed by 1 to 1.5 improved, 6 improved by 2 to 2.5, and 4 by more than 3. Well, these were stunning improvements. 2 improved by half a point, which was not. We don't consider that improvement. We need at least 1 point, but they didn't get worse, and 2 were completely unchanged, with a mean follow-up of 3 years, range 2 to 5. So if we looked not just at EDSS, but NRS, we found if this is the mean before the procedure, and standard error bar here is, so this is 75% of the patients, it just kept improving, reaching maximum improvement 2 years after the procedure. Remember, we treat one time and stop all therapy after that. And NRS is the opposite of EDSS in that it goes 0 to 100 being normal. In EDSS, 0 would be normal. So in NRS, which is neurologic rating score developed at Scripps, close to you here, just a little further south, we see this same improvement that we saw in EDSS. And those are the gold standards for looking at, in all treatments for MS, how the patient's doing. A neurologist scores their neurologic disability according to EDSS and or NRS. And that's what we did. And we kept seeing this improvement. When we did other things such as 25-foot walk, the time to walk 25 feet, you can see they're walking faster and faster. Maximum improvement is at 2 years. And when we looked at a cognitive function, ability to think, because patients would say after the procedure, the cloud, they would say it actually in the hospital before going home, this cloud is lifted from their mind and they can think better, more clearly. So we do a PASAT, Paced Auditory Serial Addition Test. This is 3 seconds. You also do 2 seconds. You listen to a recording, 3 plus 7, and you have 2 or 3 seconds to write down 10. Then it says 4, but you have to remember the prior number, which was 7 each time. So it can actually be a little challenging for a patient. And this is the percent correct. You can see they kept improving in this cognitive function for 2 years after the procedure and then seemed to stabilize. So the end result of this was that with a mean follow-up of 3 years, and I say 2 to 5, but one patient had just hit 5 years at the time of publication, we had progression-free survival of 100%. Nobody progressed in neurologic disability. In fact, 80% significantly improved in their neurologic disability. Relapse-free survival, now relapse doesn't correlate with permanent neurologic disability because you can have an attack and it can go away. So it wasn't perfect because we still had a few relapses occur, about a quarter relapse, 24%. So relapse-free survival, 76%. And the Europeans have a way of looking at MS called disease-free activity survival, which is no progression, which is based on permanent disability, no clinical relapse here, and no new lesions in MRI. And so that was 62%, or about 2/3. So we're not perfect, but we were very good. And why is that good? Because And why did Lancet Neurology publish it? Because that is the first study in treatment of MS that with treatment you have a reversal of neurologic dysfunction instead of just slowing it down. By reversal, I mean at least 1 point or better improvement. Okay, and that was the very first. And so BBC picked it up and ran it worldwide, and a lot of people kind of learned about it. So the non-myeloablative hematopoietic stem cell transplant is the only treatment that's demonstrated reversal of neurologic deficits, 1 or greater improvement in EDS and multiple sclerosis, if treated when immune-mediated. That's important, not late progressive. The caveat here, and I always have to put a caution, is, was EDS at true baseline when we started? Because we're treating with acute attacks. So if they're having an acute attack, we'd have to wait 3 months, treat with steroids, whatever, just to try to make sure they're back at their baseline before we treat. And most people, according to the literature, should be. But there's an occasional person may not hit baseline for 6 months after an acute attack. The problem is we're having 3 or 4 acute attacks a year. If we said we had to wait 6 months, we'd never enroll anybody. So that's the caveat, okay? And it's for reasons like that that you have to do the randomized trial. And the early show, besides BBC, the early show is CBS picked it up and one of our patients is on it. I was going to play that video, but I'm not going to because we don't have enough time and I need to move on and eventually get to Devix. Can we flip to the, oh, I'll go to the next slide. But if you want to see that video, it's on our website, www.stemcell-immunotherapy.org or .com, either one. You can go there. It's from CBS News, and it's on the website, and you can watch it. And because it's on the website, it's been on television, I can mention it without any HIPAA violation, and the patient was actually treated at Georgetown, and because so many active inflammatory lesions ongoing despite standard treatment, was sent to the National Institutes of Health in Bethesda, Maryland, kind of down the road. They tried an experimental study, it didn't help, and so the NIH referred him to us at Northwestern. And the interview on that website, on the early show of CBS, the patient talks and is 2 years out with no new lesions at all and no symptoms of MS, and is now actually 4 years, no new lesions on MRI and no symptoms of MS and doing very well, very young, formerly, and you know, has been, well, watch the interview. It had a fundamental impact in this patient. And I'm just showing that because that's what we saw in general of all of our patients. Now there's a study in Sweden where they did this approach that we're doing in inflammatory MS, and they got the same type of results as we did, actually even better. They did fewer patients, 8, but even more stunning reversals of neurologic disability than what we have reported to date. So where's that taken us with MS? As I say, we started animal models, then phase 1, phase 2, phase 3. So that's taken us to a randomized controlled trial called MIST. And so MIST here stands for Multiple Sclerosis International Stem Cell Transplant Trial. And it's international because, of course, it's being run at Northwestern. We developed it there. But it's also being run at the University of São Paulo in Brazil. USP, University of São Paulo, is their Harvard. And I work closely with them. I have for many, many years. It's being run at the University of Calgary in Canada, and it's also getting approval in 2 other centers. One is in Uppsala, Sweden, and one is in Prague, the Czech Republic, Charles University. I think probably Uppsala, Sweden will get the approval first and be joining us in this study. Importantly, in this study, there is blinding going on. Now, you cannot blind the patient. You just can't. It's impossible. It's not practical. They're going to know whether they're in the hospital 3 weeks or not. And I will say there's a bias among the patients that this will work. And I will say there's a bias among the neurology community that this won't work. So what we did is we have an evaluating neurologist who's blinded, doesn't know the treatment arm. And then we have an MRI reading center in another state that's blinded, and they don't know, by looking at the MRIs, who got what treatment. So you're randomized, all the centers randomize in Chicago to the treatment arm, and you either get the transplant or you get continued FDA-approved therapy. At the time we first wrote it, that was Tysabri or mitoxantrone. The salvage for this protocol is that if you progress, your EDSS, neurologic disability, increases by at least 1 point that is sustained for a continuous 6 months, and you've had at least 1 year of treatment, then you can cross over to transplant. Because the endpoint of the study is an increase EDSS by 1 point. And that, I think, the only time I've had patients get mad at me or upset is when they're not a candidate for our studies, and we tell them we can't do it, or they get randomized to a control arm. Again, it can show the bias to the patient. That's why we need some blinding. But allowing crossover has saved this study, and patients are actively accruing. What about CIDP? I'm eventually coming to Devix, because our next disease we really looked at is CIDP. So just like MS, your immune system is attacking the central nervous system, the brain or the spinal cord, or both. In CIDP, it's the peripheral nervous system they're attacking, because the Schwann cells in the peripheral nervous system, the antigens, the proteins tend to be different than in the brain, although there can be overlap, and sometimes you get CIDP and MS together, and I've seen that. But usually they're distinct entities. And so we use a different regimen, because with time we've perfected our non-myeloablative regimens, and in CIDP we're using a regimen of cyclophosphamide, rabbit ATG, and rituximab. We call it Rituxan sandwich. So our standard Cytoxan ATG, there's 1 dose of rituximab on each side of it before your stem cells are given. It's a short, 5-day treatment, 5 or 6 day. And so a little more intense than the immune suppressive regimen. I think we're getting even better results. That's my impression. But that's what we're using for CIDP. And before we start this, I want to, we're always concerned about HIPAA regulations because we want to protect the privacy of our patients. But the patient on this took this video himself and kindly agreed that we could use it at this talk and that it's okay with him that it goes on the internet. And now just wait, it'll come on. And actually, the patient is watching this on the internet from his home now. This patient came to us from Cincinnati. Most of our patients do come from outside of Illinois.
I'm 20 years old. I've been diagnosed with CIDP since June of 2006. I was hospitalized for 3 weeks, 9 days in a regular hospital and 12 days in a therapy hospital. I lost 20 pounds and I've been on steroids for about 6 months, prednisone. Currently I'm tapering. I started a CellCept regimen in November of 2006. It's now January 28th of 2007 and I am completed 13 or 14 weeks. I think I'm starting to see some improvements, but not very much, if really any. Really what my doctors have said have improved are my proximal muscles. I'm sure you know what that means, not my distal functions. It's hard for me to walk because of the muscle that pulls the feet up so you don't drag. They just aren't there. So my kind of, because I don't feel my feet or really anything below my knees, and I'm liable to trip and fall without a cane. It's just not a good thing. Thought it would be helpful if I walked, showed you how I walk, so you could, I don't know if it gives you a better sense of how better help me.
So this is before the procedure. Don't click it yet. And we waited a few more months, and he continued to decline. In fact, went on to the point of using these AFOs for support in addition to the cane, and even to the point of when he's walking, holding, besides the cane, holding onto someone's elbow. Now, this is 2 years after the procedure. Go ahead and click it.
Hi, Dr. Burt and his colleagues. My name is Kevin. I'm a 23-year-old male living in Connecticut. I have CIDP, and I received my autologous stem cell transplant in October 14, 2007. Prior to transplant, I was significantly impaired with the disease. I had loss of sensation in my hands and my feet. I couldn't write. I couldn't go to school. I couldn't work. I couldn't make meals for myself. I couldn't carry things. I fell often. I had a lot of chronic pain in my hands and my feet. I was just unhappy and very unpleasant to be around. As you can see, I've got my leg braces here and my cane, which I don't use anymore thanks to the transplant. Some of the things that I've gained back is now I'm working again. I work 3 different jobs, 3 part-time jobs. I go to college full-time. I also have gained back the ability to write. I can walk without the AFOs. I don't have any pain. Just generally, I've got a much better attitude and mood about myself. I can stand on my tippy toes, even with the mild foot drop I still have. I'd say I've gained about 98% of my past abilities prior to getting sick. I even work out at a local gym, so a lot has changed. There's not an apparent weakness. When I tell people that I've been sick, they're confused. When I park in the handicap spots because I still have a foot drop, people look at me like I'm doing something wrong or illegal. So I'll show you in the next bit my walking and my running. I'm going to run now.
I think it kind of stopped, but that's okay. So, oh goodness, if you can fix that and go back to the next slide.
Okay.
All right. So that brings us to Devix, and I again want to give special thanks to my patient here who allowed and actually sent us these videos for you to see. The CID protocol is still back in phase 1, just like when we did MS 1, 2, and now randomized study. So we have a ways to go with this, and I'm sure we'll learn that there will be some in which this will not work, just like we learned in MS, the right group to treat. And now I feel comfortable. I know who to treat with MS. So that brings us to Devix, and that's one of the questions again about who's the right group to treat, not only in terms of poor prognosis. If there was a biomarker you could identify and say, get this person before they have significant disability, but they're going to go down fast, be in a wheelchair, be blind, be paraplegic, quadriplegic, that would be the perfect candidate. That doesn't exist yet, so I applaud all the people here who are trying to support research to find biomarkers to help direct who we should treat more aggressively. But the other thing about Devix is, again, when we first started this, if I were to base it entirely on my experience with MS, I wouldn't have treated the first 3 patients we treated. In fact, our 4th patient now is in-house getting treated and watching this from her hospital room on the internet. But and the reason is that we've been taking people. I think the ideal group would be having frequent attacks but going back to normal baseline between attacks. But we've been taking people who don't seem to go back to normal baseline and have persistent disability. A group that if it was MS, I would say is secondary progressive and I wouldn't treat them. And we're early with 3 patients treated, but we're seeing improvement. So I am seeing something different with MS. It is a different disease in how it's responding to treatment than with Devix or neuromyelitis optica than MS. And the other thing, is we'll get a patient and they'll have this kind of baseline neurologic disability, and they'll be complaining to us about that band sensation And we find that's kind of chronic. And again, the question came up, is that related to active disease or neuropathy or whatever? After this procedure, that goes away. And so we've had some, but we're early, so I still don't know. We have to complete at least our first 10 patients, get a better handle on what group this is really going to help, which it isn't. And I'm sure if we take someone that's, been in a wheelchair a long period of time, just flaccid paralysis, I don't think it would help them. But I just want to show you one of our patients again was kind enough to send a video of how he's doing after this procedure. And again, the 3 DEVICs we have, I don't even think have hit their 1-year follow-up yet, so it's still early. But I'll let him speak in his own words here, and I'm very, again, grateful that he's allowed this for you to see. Oh, and here's our regimen. It's the same regimen we use in CIDP. It's our Rituxan sandwich regimen. The reason I bring that up again, there's this, from people outside the field, this attitude, well, a transplant's a transplant. No. The toxicity and the efficacy comes from the conditioning regimen, which if you make different, is different. Just like you don't say, well, the efficacy and toxicity of azathioprine is the same as CellCept, the same as rituximab, the same as Tysabri or natalizumab or whatever. You know it's not the same. In transplant, the toxicity and the efficacy comes from your regimen that knocks your immune system down. It's that rebound from the stem cells and the default mechanism regenerating a new immune system in which you can get tolerance to self-antigens, the hypothesis, and now we have data supporting that. But at least in MS and some data at least in lupus and some data in MS. But you have, not all transplants are the same for people outside the field. I think that's confusing.
Let me tell you a little bit of history about myself. I was diagnosed in 2006 with Devic's disease and multiple attacks. I had a major one at one point and was paralyzed from the neck down, and I was confined to a wheelchair and a walker for approximately 2 years. And then I found out about the stem cell transplant at Northwestern University on the internet of all places. And so here's my testimony to show how well I'm doing. See, I rode a bike, I can walk.
I don't get it anymore.
Gonna try making a basket. I can jump. I don't get dizzy anymore. I don't get nauseated. I'm just doing so much better. I just want everyone out there to know that this is a cure. There's no more. I don't have to go through any more medical procedures. Dr. Burt, number 1. Thank you.
Well, thank you to my patient. Oh, here he is riding his bike. So, can you put up my next slide? So, I appreciate very much what makes it rewarding is to see these kind of responses in patients. But I never use the word cure, never. In fact, all these diseases have no definition of a cure, and I don't have the crystal ball to predict the future. But it is a paradigm shift in that we do one treatment and stop all therapy, and we see reversal of disability. So just as the Wright brothers in the first airplane flight, I think it was 17 seconds, and look what it became. So, I think we're changing the field of medicine, and a lot of people in the future will help contribute to refine this and perfect it and make it even better for patients. And we'll learn a lot on the way in doing it. So I also, at this point, we've done, as I mentioned, we're doing our 4th patient. All 3 that we've done so far have had improvements, reversal of neurologic disability. And I'd like to invite Mr. Stecker, our patient, up here, if you will. So I know I got flagged for time, but if we can have 1 or 2 questions for Mr. Stecker.
Dr.
All right. Thank you. So, anyone have a question? Yes.
From the time that you were first transplanted to the time that you started to walk or recover, what period of time was there that passed?
Within the month, I was walking with the cane. I mean, I got home the day after Thanksgiving, and by Christmas, I was walking around the house with the cane. So yeah, it was real quick. It's amazing.
One more question now, and then Mr. Stecker will be available, of course, later.
Are there any major side effects? I mean, other than it wouldn't work, I mean, is there anything majorly that can go wrong with the transplant? I think that's a doctor question. I'm just
Yes, no, there is. And, we have a consent form and advise the patients. And the worst thing could go wrong is someone could die. And that death could be related to, if it happened, most likely would be infection during the period they're neutropenic in the hospital. Now, we've probably done a total of 120 MS patients, and we're up to 14 CIDP, and we're doing our 4th DEVIX, and we've never had a death in those patients. But you can never make that zero. Now, we're very good, and to keep mortality very low, you need an experienced team. And you need kind of two things. One, a team that came out of transplanting leukemia, but then two, a team that's focused on autoimmune diseases and not leukemia, because they're different. And you have to learn that disease, and you have to learn this non-myeloablative approach that's different. And then, you have to know how to be preemptive to prevent infections. And then it can be a pretty simple procedure. In terms of other organ injury, no. In fact, when you do transplants for cancer, because you use all these chemotherapy drugs, if your kidneys are bad, your liver bad, your lungs bad, you can't do it because it can't take the stress. But we do certain diseases such as lupus with these non-myeloablative regimens where their kidneys are failing, they're coughing up blood, their lungs are failing, or systemic sclerosis where they're on oxygen and their lungs just are becoming, have a lot of ground glass and even fibrosis. And after the procedure, they actually get better. So it doesn't cause other organ injury. The other one potential significant complication that's late from our regimen is infertility. Okay, and that's age dependent. So if you're under age 26, it's very unlikely. If you're over age 32, it's quite likely. And so we always advise, no matter what the age is, that you have store sperm or oocytes or whatever if you want to have children. But I also advise them, don't think of it as birth control, especially if you're under age 26. 98% of the patients retain fertility, and I don't want them surprised. But it's not impotence. Actually, if you're feeling better and you're doing neurologically better, you have more desire. That's not the issue.
I just have a quick yes or no question. Is this treatment or procedure covered by insurance, or do you have to pay out of pocket?
So at one point in my development of this, as I mentioned, with doing this for 24 years, I had a large $10 million NIH grant focused on autoimmune diseases. But the NIH would not pay for the transplant, despite the help and funding for infrastructure, but they wouldn't pay for patient transplants, and that had to be done by insurance. That money's long gone now, but it is insurance still that has to pay for this. Now, in the process, we have presented our data all the way from animal studies to outcome data on published papers, phase 1, 2, and ongoing 3, in all of the peer-reviewed journals we're publishing, and to Medicare. And so Medicare will pay for this. They approved it for most of our diseases. Some they're still waiting more data on. There are some insurance companies and we've done it with different states. Medicaid in Illinois pays all the time. Medicaid in New York pays, and that was because we had so much referrals from New York. I became a Medicaid provider for the state of New York. It was paperwork handled by our hospital. I don't do it directly to allow that to happen. Some states, California, Medi-Cal does not pay, never has, even though we get a lot of patients coming from California because, again, a large population base here for these treatments. So that's state dependent. And then insurance companies, it varies. So there are some insurance companies reviewed it and they made a decision they always pay for it. thank God for those insurance companies. And then there are some where and I don't want to get in trouble by giving names one way or another, and there are some that it seems very capricious in that about 67% of the time they pay, the rest of the time it's a major, major fight, or they don't pay. But it probably has to do with plan variability, employer variability, state variability, and things like that, details of things that I'm not aware of and don't exactly have the time to get involved in. But we do work with the insurance companies. We provide them about the patient. We give them a list of our publications. We talk with them on the phone and with their reviewers. We spend a great deal of time in the background trying to help to make sure that this can be made available to the patient if they're a candidate and if the patient wants it. Yes.
Yes.
I think, I'm sorry, but I'm getting some hate mail from the back there. So this will be the last question.
Okay. I'm Marcelo Mattiello, Mayo Clinic, Rochester. We just sent out a case report to Archives of Neurology of a patient, NMO patient, and you may know that by communication with Brian Weinschenker. She was treated with a stem cell transplant for a lymphoma, but she had a relapse after 4 months, a bad NMO relapse. And on the discussion of this case report, we formed a couple discussion review papers that pointed out that for antibody-mediated diseases, it may not be as efficient, or the efficacy may be different. I was wondering if you have experience with myasthenia gravis or diseases that may be more related to NMO in a sense of a similar
right. So I have to caution you. It's what I said earlier. A transplant is not a transplant. Don't lump them all together. The safety and the efficacy depends on the regimen you use. So they used a regimen not designed for an autoimmune disorder, but for cancer.
Sure,
okay, and that's not what we do.
Sure,
and
I understand that.
We've also found, in the statement that you don't think is as good in B-cell mediated.
That's the opinion we got from different hematologists.
I know, but that's not at all our experience. We've done more transplants for autoimmune disease than anywhere in the world, having pioneered it. What I can tell you is that when like for instance, lupus, we used our Cytoxan ATG regimen on very refractory case, organ-threatening, life-threatening lupus, did 50 patients. We reported in JAMA, Journal of American Medical Association, the disease-free probability at 5 years is 50%. You do treatment and you stop. Well, at 50% had relapse. So, you can say the glass is half full or half empty, but we began with an empty glass, refractory disease failing everything. Now, since then, in our lupus patients, we used our Rituxan sandwich protocol. We're seeing a much lower relapse rate, much lower. And that's the regimen we use with CIDP and with from the beginning, and with Devix from the beginning because of the antibody-mediated nature. That's why we added the Rituxan in each end of the Cytoxan ATG. Also, how you mobilize the stem cells is important, and we use 2 grams of Cytoxan per meter squared. That's a big dose for mobilization. That helps as an in vivo purge before you put them in. So, individual case reports are of interest, but just as we've all said here, in the end, you always want randomized studies, and you have to be careful extrapolating an individual case done for different disorders. In fact, before we ever got into doing patients' autoimmune disease, the other literature was always combed and reviewed of case reports for transplant for cancer and what happened in the autoimmune disease. And generally the results were favorable. Sometimes there were relapses. But the problem was you're just picking up a lot of stuff, and a lot of cases aren't reported. You're just getting what's being reported. So I think if you focus in this area, if you follow the concept of non-myeloablative, maximize the immune suppressive component of your regimen without the myeloablative toxicity, you can get, at least we've been getting in a variety of different diseases, much better results than what you mentioned in that one patient treated for lymphoma. Nevertheless, it is always important, and as I say here, never say this is a cure, but it is a step forward, and as we learn and perfect what we're doing, I think the results with time can only get better in terms of safety and efficacy.